pharmacogenetics more as a specialty practice in psychotropics. So I think if we can save questions for the end, we'll kind of go through our two different perspectives and then share questions then. So our goal with this presentation really is to make sure that you can walk away kind of recognizing some of the known barriers and facilitators to pharmacogenetic implementation, share or describe some of the pharmacogenomic resources which really help leverage implementation and research, illustrate through a couple different examples ways to integrate and evaluate pharmacogenetics in clinical practice, and then consider how non-genetic factors can impact interpretation of genetic findings and demonstrate the utilization of pharmacogenetic results, specifically with psychotropic management. So I'll start with some considerations for really establishing pharmacogenomics implementation initiatives. This is something I think that more and more centers are looking at and thinking about. And so in my role as a clinical pharmacist here at University of Michigan Health, I really help to lead the implementation of pharmacogenomics broadly into clinical workflows across our entire healthcare system. And so I want to spend my time today discussing the considerations for using pharmacogenomics at a systems level and share some strategies that might help increase the application of this type of information across the system, especially when we think about some of the interdisciplinary considerations for these findings. When I get questions about starting pharmacogenetic services or thinking about pharmacogenetic services, I usually get asked why. So why should we be implementing? Why should we be thinking about pharmacogenetic test results in practice? And so generally, I think there's a perception that genetic variation is rare. But that's really not the case when we think about pharmacogenetics. There are numerous studies that show that almost every person carries at least one currently actionable variant where they could have a personalized prescribing recommendation. But just because you have the genetic variant doesn't mean you'll be exposed to the medication that's associated with that risk factor. But there have been a couple of different sort of population level or biorepository level studies that have estimated that anywhere between 30 and 60% of individuals will receive one of the medications that's associated with the genetic variant that they carry. And so these can be very commonly prescribed medications. Kristen's going to talk about psychotropics specifically, but other common medications like statin therapies or proton pump inhibitors or pain management medications like NSAIDs all have pharmacogenetic recommendations that could be considered for patients. And then there's increasing amount of evidence showing that pharmacogenetics guided treatment can help reduce the rate of adverse events associated with medications and may help reduce healthcare burden in terms of resources by reducing the number of ER visits or hospitalizations in patients who are receiving genotype guided treatment. And I think finally, the cost of genetic testing is decreasing and the reimbursement for this testing is increasing. And so, and there's also now emerging scenarios where pharmacogenetic findings are being returned for free as incidental considerations off of other types of genetic test reports. So I think as we approach the question of why implement, the availability of this information is only going to continue to increase. Patient interest in this information is only increasing. And so because the potential impact on medication safety can be really significant, it really is becoming an important consideration when we think about medication utilization. So despite that evidence and some really well-known pharmacogenetic interactions, integration into practice is still not routine. And many groups have kind of evaluated what the barriers are today and remain today. And so I quickly would just want to review those in the context of pharmacogenetics. So a really commonly cited barrier is information technology limitations. Genetic results are lab results, but they're reported differently and often interpreted differently. And the other thing is that they're not time sensitive, meaning we might know a genetic finding for a patient, but they might not be prescribed that medication that's impacted by that result for years. And so with our typical laboratory reporting in the EHR, it can be very challenging to report and track the results of this test in real time, which can prevent its utilization. Another commonly cited barrier is the availability of scientific evidence showing the utility of pharmacogenetics. every drug gene pair kind of has a different level of available evidence. And in many cases, we don't have randomized controlled trials, sometimes because it might be unethical to actually perform that type of evaluation. And so we need to think about what groups have evidence for efficacy or not. Another barrier is the testing process. Sometimes this can be challenging to navigate for providers, or there could be concerns that the turnaround time might actually delay needed care for that patient. And so thinking about these considerations in your workflows is really important. It's also been very well documented that education is a barrier. There's multiple clinical specialties that have been surveyed that show they have really limited confidence in how to interpret and apply a result, or a lack of knowledge regarding what resources exist to help guide them in that process as evidence evolves. Regulatory concerns are also cited. Genetic tests sometimes can be concerning to patients. There might be concerns about discrimination for genetic findings, or other regulatory requirements such as consent that differ from other laboratory tests. And then I think the final barrier we hear about frequently and is frequently cited in studies is just cost and reimbursement. How much is it going to cost the patient? How much is it going to cost the healthcare system? And what is the potential ROI on investing in testing? So it's kind of a downer to start with the barriers, but I think that they're really not insurmountable at this point in time. And I hope through the remainder of my section of this presentation, we can show you that there are some very easy steps to help overcome these. And so one of the biggest things that has been cited and reported as the major facilitator for success of integrating pharmacogenetics in practice is having a pharmacist advocate and a clinical champion within that discipline that can really push forward, demonstrating the value of pharmacogenetics in your practice. Ideally, these are individuals who have some additional training or education in pharmacogenetics. Another thing to think about that's a resource that I think is still not commonly known in the broader clinical community is that there are available clinical practice guidelines specifically for how to interpret and apply pharmacogenetic information into practice. And some really new, unique interpretation resources that make that process even more efficient for healthcare providers. And this can help reduce the training and education barrier that exists for implementation. So when I think about an implementation process as we're thinking about adding new pharmacogenetic recommendations to our system, I really divide this into kind of 6 key steps or decision points. But I have this listed as a continuous circle rather than a straight list because the choices made for one area often will then impact what options you have for the next step in that kind of decision-making process, or they might inform each other. Sometimes they're also completed in parallel, just depending on your institution. So I want to spend some time discussing some of the major considerations for each of these decision points in pursuing a pharmacogenetic implementation. And I think these hold true regardless of what medication or clinical area you're working within. So the first step oftentimes is selecting the drug gene pair or pairs of interest that you want to implement or integrate within your system or practice. Some tests that are available commercially have reports that include hundreds of potential drug gene pairs that are reported. But as we think about the processes, it may not be feasible to implement them all at once. So to narrow down your focus, what I really recommend doing is identifying what drug gene pairs have high levels of evidence. And the two resources that we primarily utilize to establish a high level of evidence of utility is clinical practice guidelines from the Clinical Pharmacogenetics Implementation Consortium, or CPIC, or medications where the Food and Drug Administration has made requirements or statements about the impact of pharmacogenetics on their prescribing. So CPIC is an NIH-funded consortium that develop evidence-based guidelines for how to apply a pharmacogenetic result into patient care. So when you have a result in hand and you're thinking about prescribing a medication, what do you do to that medication? Do you avoid it? Do you modify the dose? Do you consider different types of monitoring given that pharmacogenetic risk? One of the things that CPIC does not do is provide any recommendations for whether or not to obtain testing. So they really come at the recommendations assuming that you have those results in hand. The Food and Drug Administration has two different resources that might be relevant. The first is the pharmacogenomic biomarkers in drug labeling. This is really the only source in the US that will provide statements about requiring testing. So if testing is required per the drug label. And then they also have the table of pharmacogenetic associations, which breaks down sort of their thresholds of evidence for different drug gene pairs. So if a medication is included in these resources, there's a pretty high likelihood that there's a high level of clinical utility in terms of pursuing implementation. Another advantage of looking at these resources is they're often tied to testing reimbursement, and so they might help increase that likelihood of the cost barrier if you utilize their medication list. Other things you might want to think about as you're prioritizing a drug gene pair for implementation is the impact of that pharmacogenetic finding on medication safety, the clinical interest of the teams that are going to be impacted by that testing or the prescribing recommendation, testing availability. Sometimes there are not necessarily clinical grade tests available for a genetic marker of interest. And then also sort of your clarity of your intervention or having an alternative to recommend to your providers if you find a genetic risk. Another resource I want to highlight that can be really helpful, and this is a revised resource, is called ClinPGX. So this used to be called the Pharmacogenomics Knowledge Base, or Pharm.GKB. This website is essentially kind of a one-stop shop for pharmacogenomic interpretation and application. And they curate all of the available literature on drug-gene interactions. So it can be really good for getting a quick assessment of what is the level of evidence for a drug-gene pair. And it also curates all of the CPIC guidelines and FDA recommendations. So rather than having to go to multiple sources to look at those lists, you can come to this single source and find that information. Another newer feature on this website, which I think is one of the most helpful things as a clinician utilizing this information in practice, is their interpretation tools, which are called the Genotype Selection Interface, or GSI, or their tool called Pharm.D. And these resources allow you to enter genetic results from any pharmacogenomic report, interprets those results according to the CPIC guidelines as a standard, and can give you a comprehensive output of all of the medications that have actionable recommendations from the available resources. So I have a quick example here where I put in a CYP2C19 genotype for a patient. It gave me the phenotype of intermediate metabolizer, and then it's telling me that there are 13 unique medications that have recommendations for this particular patient's phenotype. So this can be really helpful for clinicians and they're evaluating pharmacogenetic results from multiple laboratories or panels, or when they get a disease-specific report where maybe the genes have interdisciplinary considerations. Once you've determined which drug gene pair makes the most sense to move forward with in terms of implementation, the next step, or parallel step potentially, is identifying who are really the stakeholders for the implementation. And when I think about stakeholders, I think not only the prescribers, but thinking about the design of the implementation as well as the end user who's going to see the pharmacogenetic information. So the prescriber is a primary stakeholder. They're going to be the one potentially ordering the testing and or ordering the medication. And so if they really don't buy into the testing or don't buy into the recommendation, all of the effort you put into building that integration might not come to fruition in terms of an impact on patient outcomes. Other key considerations are likely your laboratory group and your informatics department to help determine how testing will be performed and how you will access or display the results on the back end for clinical decision support. The ideal state is to get these results into your electronic health records so that they have the ability to be applied across all interdisciplinary teams and throughout a patient's lifetime for their care at your institution. Patients might also be very important stakeholders, especially when you're thinking about the type of testing that they would value having performed, what they might be willing to spend on a test if it's not covered by insurance, or any other concerns they have about genetic testing generally, and that type of education. Most institutions don't have in-house pharmacogenetic testing laboratories, so selecting a commercial lab or send-out lab is often an implementation step. But I think pharmacists can also help inform the development process if you are developing an in-house test by thinking through these kind of key questions. One key thing to keep in mind as you're looking at commercial labs for pharmacogenetics is just because two labs report on the same gene does not always mean that they're looking at the same information in terms of which genetic variants they're looking at, or that they're reporting the information in the same way, which is why we really recommend utilizing those ClinPGX standardized interpretation resources. So that way, regardless of the laboratory, the interpretation and application becomes the same. So when thinking about a laboratory, there's four key things that I kind of ask questions about or assess. And the first is looking at what gene or genes and variants are included. This has a couple of different considerations. The first is whether or not there's even a clinical grade test available for the gene that you're interested in. And there's an online resource called the Genetic Testing Registry that labs can voluntarily enroll with that can help give you a sense of if they have an available test. Another thing to think about is whether you have a preference for single gene tests or panel-based testing. There can be some benefits to each of those unique considerations. Panels might be more cost-effective in the long term, but a larger panel isn't always better, as sometimes there are genes that are included that do not currently have actionable recommendations for personalized treatment. And so that can cause confusion for patients and providers if they're seeing all of this information that they don't know what to do with. And the final thing I always like to assess when available for laboratories is looking at the variants that they include. And so the Association for Molecular Pathology has started to publish recommendations for the minimum variants that certain pharmacogenetic tests should be including. And so if a lab does not include these variants, there's a higher chance of misclassifying the patient's genotype. And so this is kind of considered best practice in terms of making sure that the lab has those included. Another really important lab consideration is the logistics, thinking about what type of sample will be used. Some labs will allow blood, buccal, or saliva samples. If you're doing buccal or saliva samples, how will the kit get to the patient? Will that be collected in clinic or will it be mailed to their home? And what does that return process back look like? It can also be a major question of how long will it take to get the test result back, depending on the genetic or medication scenario you're thinking about. You might need that result back very quickly, or it might not matter if it takes a couple of weeks to have that result returned. And so those are questions that are really, really important when selecting your laboratory for different clinical implementations. Cost of testing is also an important consideration. Some commercial labs will work directly with the patient insurance to facilitate billing and may offer a cash price to patients so that there's a limited out-of-pocket cost and no impact on the institution. But some labs will bill the institution directly or go after reimbursement. And so there's a lot of variability here in terms of those workflows. But those considerations might impact which lab you choose to move forward with. As I mentioned, the reimbursement of pharmacogenetics has been increasing. And so I do want to mention that in most CMS Medicare administrative contractors, there are limited coverage determinations that do include coverage for pharmacogenetic tests, as long as the medication has a CPIC guideline or FDA recommendation. And so generally patients with Medicaid and Medicare can expect to not have to pay anything out of pocket for these tests, which is nice. The last question I always ask of laboratories is, how are these results reported? Many labs send the results as PDFs, but they really would be better if they're integrated. And so a critical question is to ask, how are they coming back? And then what level of evidence are they using to make any recommendations? In terms of thinking about visibility of results, it's really recommended to develop a method where your institution can indicate if a patient has had pharmacogenetic testing, or as much as possible document the specific result for that patient so that reminders of the pharmacogenetic implications of their findings can be integrated into clinical workflows. And that's primarily done through clinical decision support tools in the electronic health record. The type of clinical decision support intervention can vary widely based on your institutional approach or integration. But as much as possible, really following these 5 rights of CDS integration in the development of these tools so that they're tailored to your existing workflows and the needs of the teams that are involved in testing and prescribing, I think can really increase the success of these interventions. The final aspect I think from a program level to think about is navigating the implementation of pharmacogenetics through your own institutional approvals and workflows and thinking about educational success there. So there's been quite a few groups that have published on this. Most pharmacogenetic programs are managed through the Pharmacy and Therapeutics Committee or subcommittee within their institution. And those pharmacogenetic recommendations, therefore, might get tied into the medication use considerations or dosing recommendations. Other considerations might be medication safety interventions, if especially for some of the drug-gene interactions that can be fatal, ensuring that those are integrated into the prescribing workflows to prevent those avoidable adverse events from occurring. And then I think another main consideration is education. What education is needed for your clinicians as well as your patients. And again, this might differ based on how you're choosing to implement or what drug gene pair you're choosing to implement. Some strategies that have been reported include education that's really provided within the clinical decision support, so that real-time intervention education to your clinician. Some centers have published on pharmacogenomic case conferences within the different departments to really teach providers about pharmacogenetic interpretation and application. And some have more general competencies that providers are expected to complete. Patient education, I think Kristen's going to talk a little bit more about this, but thinking through what patients need to know about the testing before they complete it, as well as post-test education and what they should do with their results. And the last point I think is really, really critical, but sometimes overlooked, is there really also needs to be a consideration for the maintenance and upkeep of these initiatives. Pharmacogenetic recommendations change over time as evidence changes. And it's also really important to make sure that the intervention you're putting into your electronic health record is functioning as intended. So some form of intentional assessment of these pharmacogenomic systems is a really important aspect to a successful program. So I'm coming short on my time. I want to make sure we have things at the end so I can answer any questions about this. But I just had a couple slides with some examples from one of the larger implementations we've done here in kidney transplant patients, sort of walking through what we did at each of these 6 steps. And so I'm happy to take questions about that later, but I want to make sure Kristen's got time for her section as well. So thank you very much for your attention, and I'll turn it over to Dr. Ward.
Great. Thank you, Dr. Pasternak. Am I coming through okay too? Awesome. All right, and thank you to Dr. Salgado and the group for the opportunity to join you this afternoon. Could you go to the next slide? All right, thank you. In this section of the material, I'll be reviewing how we support pharmacogenetic testing needs for patients and providers in ambulatory psychiatry. There'll also be a brief note about billing and an overview of the quality improvement and research projects we are working on. Before diving in, just for a little bit of context, in ambulatory psychiatry, there is a 0.4 FTE, so about 40% of the week, of pharmacist support for the entire department and psychotropic-related pharmacogenetic testing for the health system. So what this has looked like over the past half a year or so is about a quarter of our week is related to pharmacogenetic pre-test and post-test discussions with patients. Next slide, please. Before hopping into the pre-test education discussion, I'd just like to begin with a note about expectation setting. One of the things that is sometimes a little bit unique about pharmacogenetics and mental health is that most of what we learn from testing is about dosing, which does not always lead to marked improvements in medication outcomes. And that is counter to what many providers and patients think that this testing is capable of. So put another way, this is not like that old expression, a silver bullet that will guarantee improved outcomes in an end to trial and error prescribing. And this is really important, especially when you're talking with patients about testing and test costs, because oftentimes when they're at the point of pursuing pharmacogenetic testing in psychiatry, they could have been on 3, 4 more antidepressant trials that have taken a solid 3 months per trial. So they're usually pretty fed up, frustrated, not feeling well, and at a point where they're ready to consider this testing. Next slide, please. So why is it the case that pharmacogenetic testing in mental health doesn't always lead to like massively improved outcomes like maybe we were hoping for, 10, 15 years ago. And it's probably due in part to many of our medications, like SSRIs or selective serotonin reuptake inhibitors, having a pretty wide therapeutic window so that minor changes in metabolism don't massively change outcomes. Additionally, most of our CPIC guidelines and the FDA-approved package inserts are related to two metabolizing enzymes, CYP2D6 and CYP2C19, and select antidepressants and a few antipsychotics. But what we're trying to show with the pie charts here is that the most profound changes in metabolism, so the people who have like zero enzyme activity or have super, super, super fast enzyme activity, that's only a pretty small subset of your patients, so who are those poor and ultra rapid metabolizer phenotypes. So 12 to 13% of people, when you do averages of the global population using like CPIC supplement data. Next slide, please. The exception to the most of psychotropic pharmacogenetics being about dosing adjustments is related to the human leukocyte antigen presenting genes. There are increased risk for variant carriers to have potentially fatal immune mediated adverse skin reactions. This is a bit of an easier result to act on in practice. So patients who are carriers of these variants should avoid the medications if possible. But the other thing to think about in clinical practice is that not many people in psychiatry end up on the medications that might be impacted by the results. So carbamazepine, brand name Tegretol, for example, is really a third line medication in bipolar management and not used that frequently. Next slide, please. So to recap the last two slides, we have guidelines and package inserts to guide select medication use and dosing based on primarily CYP2D6, CYP2C19, and HLA variant carrier status. That isn't what is happening in practice. So to pull from Dr. Pasternak's material, more is not always better. For institutions or providers who don't have access to, say, a health system, your kind of own at-home pharmacogenetic testing panel, you're going to end up working with a commercial pharmacogenetics lab. And they're typically including a mix of high-level evidence for implementation variants and low-level evidence variants, and using them in concert to make medication recommendations. I took the details of this study out to save time, but there's a really cool 2018 paper by Dr. Chad Bozeman and his colleagues where they sent samples from 5 different patients to 4 different psychotropic focused pharmacogenetic testing companies and compared congruence in the reports. And it was all over the place. They weren't always testing for the same variants. They weren't always interpreting the same variants the same or making the same medication recommendation for the same patient, which is pretty alarming to see that much variability in only 5 patients. So I would check that out. If you're interested, I can send the full citation. When I present that study in full, though, and try to use it for our clinicians, my kind of take home is look at the actual genetics, not just the pretty medication color coding in those reports. So next slide, please. So what happens when we use these like panels, these commercial panels in large randomized, somewhat controlled trials? In 2018 through 2022, some of the biggest RCTs were published that took patients or enrolled patients with depression or anxiety, basically randomized them into their providers getting the pharmacogenetic report and their providers not getting the pharmacogenetic report and compared outcomes. And what they found generally was that there were improved outcomes measured by things like patients achieving remission or response in, say, depression or anxiety in the pharmacogenetic guided group. but those improvements over the non-pharmacogenetic guided group were not tremendously big. The effect size wasn't super high. There were a couple factors that were associated with more likelihood to improve if the patients got pharmacogenetic testing, and those included patients who had more severe symptoms at baseline, patients who were likely poor or ultra-rapid metabolizers, and patients who have had more failed past medication trials. Next slide, please. And later, after those studies and several more were published, a team got together and they did a pretty careful meta-analysis of 13 different trials, and they basically found the same thing. Testing is associated with improved remission rates, but the effect size wasn't huge, and it was correlated with severity of symptoms and number of past medication trials. There were also a number of limitations. Most of the patients were enrolled in studies that used the GeneSight product, which is just one of many commercial pharmacogenetic testing tools. And there was not a lot of ancestral variability in the group. Most enrollees were identified as white females. Next slide, please. So pulling all this together, we know that testing can help. It's probably not going to help a ton unless we find out our patient is an ultra rapid or poor metabolizer, and we don't know until we test. So all of this becomes really important when you're talking to patients about expectations of testing. You don't want to advertise this to them as something that's guaranteed to change their life. And some other important discussion points we think about in pretest counseling are that, patients might be on more than just the mental health meds, even when they're doing this to guide, like, say, antidepressant use. So you have to be aware of that. And there might be the cost that Dr. Pasternak's spoken about a couple times. Next slide, please. So when we're doing these pretest counseling sessions, usually the biggest barrier to proceeding with testing is cost. Patients who have Medicaid or straight Medicare don't have an out-of-pocket cost, but all the commercial plans typically do. Logistics, thankfully, aren't too much of a barrier to testing since they all offer shipping a cheek swab to patient's house and they can just ship it back. They don't have to go anywhere or get a blood draw. And then another thing to think about if a patient is maybe on the fence for testing or which testing product to select is, are there other non-psychotropic medications that might be impacted by the results? I'm going to bypass the statement about options because Dr. Pasternak covered that really well. Right, next slide, please. So pretending that you have a patient who's agreed to testing and their reports coming in, one of our roles in the clinic is to review the report, ideally talk about it with a patient, but sometimes we're not always pulled into the post-test consult, and consider the pharmacogenetic results in concert with the non-pharmacogenetic factors your patients might have that could help guide the next step medication. So non-genetic factors include things like phenoconversion. Wellbutrin, generic name bupropion, is a very commonly used antidepressant that's also a strong 2D6 inhibitor. So if your patient is taking Wellbutrin, but they're a normal metabolizer per their genetic report, the Wellbutrin is going to phenoconvert them into a poor metabolizer. And that phenoconverted poor metabolizer phenotype is what you should be using to make medication recommendations for meds that go through the 2D6 enzyme. You also still have to think about renal and hepatic function when you're interpreting the reports. We have a lot of patients with comorbid conditions that might benefit from an antidepressant that can also help with neuropathies. And then again, coming back to what other medications might be impacted by the results. So we work commonly with two products. One product is considered comprehensive and they include psychotropic and non-psychotropic medications on it. But the other product, GeneSight, that we work with, they interpret the genetics just for mental health meds. So you might see someone who's a 2C19 ultra rapid metabolizer. There's going to be no interpretation on that report for proton pump inhibitors. There will be for the impacted antidepressants like Lexapro or escitalopram and citalopram, but not anything that is not considered a psychotropic medication. Next slide, please. The post-test encounters with patients are a lot of fun, and everybody wants something different. We'll have patients who are like, "Yeah, let's just go over the big picture," and then the next patient call could be someone who's read the full report in depth and wants to know everything they can about two specific non-normal results on it. So when we're doing these post-test results, we're always trying to tailor the discussion to the patient, but we always try to, or we always do hit upon results that might be important for safety considerations like those HLA variants, and encouraging patients to keep a summary of the results with them because as Dr. Pasternak pointed out, not everyone can store these pharmacogenetic results in a way that can trigger clinical decision support alerts, especially if you're changing health systems and going from somewhere that can do that to somewhere that can't do that. And we do have patients who want, everything, every resource they can have. And there's a lot of great open source or materials that aren't behind a paywall. Next slide, please. So my last several slides are more about clinic volume and quality improvement projects or research projects. And a lot of these are done with our Pharm.D investigation pharmacy students. So this is kind of a capstone longitudinal research project. And in the first, Ashley Sayi did a fantastic job with retrospective chart review of consult notes that were written after reports came in. And the premise was how much additional kind of value is a pharmacist consult adding to the report? Because the report only reflects on medications and genetics without knowing anything else about the patient. And we found some pretty interesting results. So Ashley noted that there was a fair amount of phenoconversion. Almost a little over 40% of the patients had potentially major drug-drug interactions. So we're not talking about like Lexicomp B level that flags for everything under the sun. We're looking at more serious potential reactions. And then almost 50% of our pharmacy recommendations to the prescribers were based on non-pharmacogenetic factors. What was really fun about Ashley's study was that she found in a little over 85% of patient cases, the provider or prescriber visits that followed the pharmacist consult note copy pasted our recommendations into their next step encounters or referenced our note when they were kind of putting plans in their note for the patient. So that was really heartwarming to see. Next slide, please. And then another pharmacy student, Vicky Tang, did a short provider survey. We had 29 respondents, which is pretty good considering a lot of the people we help order tests are residents who kind of come and go. She found some positives and some areas for improvement that we're working on. Some of the positives really enforced our kind of stressing for we should be doing these post-test calls more regularly. And some of the areas for improvement were making them easier to understand for non-psychiatrists, which we are trying to do. Next slide, please. We've got some kind of like volume metrics for you here, not from too far past starting in May 2025 through February of this year. But basically, this is just how our volumes changed over these past several months. And then the dark blue and yellow bars in the figure on the right show how our pharmacogenetic consults vary in whether or not they're coming from our ambulatory psychiatry team, which is blue, or say like primary care or internal medicine, which is yellow. So we think the support's basically asking for more pharmacist time to help be a resource outside of the department where we technically work, which is ambulatory psychiatry. And as a quick side note, when we do these encounters, we're billing under care management codes. And I think that is it. If we go to the next slide, just wanted to say thank you for your time and what questions can we try to answer?
This was excellent. Thank you so much, Doctors Ward and Pasternak. I know we have some people here in the audience that have experience implementing pharmacogenetic testing in the community-based settings. So I will let them speak if they're interested, but I would be interested in hearing your thoughts as to how you think that plays a role in community-based settings, in the community-based pharmacy beyond the health system.
Yeah, I think it's an area where we need more advancement. Especially when we think about patients maybe having access to this testing and it impacting over-the-counter prescription, or not prescription, over-the-counter medication decisions like guiding NSAID selection or proton pump inhibitor therapies. But I also think having the community pharmacist as that safety double check before they're dispensing a prescription like clopidogrel or something where there's a risk that we can talk about, or maybe capturing some of those phenoconversion events in patients. I think it's an area that can only benefit patients, and safety. But I think there's a lot of challenges in terms of interconnectability and sharing of data, which we need to improve on too.
Yeah, I just second Amy's comment because I know when we're doing our patient encounters, we are regularly, most patients catching that our medication lists are not comprehensive. So I think the pharmacist could be a fantastic safety check.
Hi, I do have a question. My name is Tana Kafer, and I work at Bremo Pharmacy, and we do offer pharmacogenetics testing in our pharmacy. And so I was very intrigued when you all talk about working with a hospital lab versus a lab in the community, which is all that we have, right? Those are the choices. And I can tell you over our probably 10 years of offering this service, we've changed labs probably 5 times. And so I'm interested if you have sources, and I did take some notes about what questions we should be asking these commercial labs when we are trying to set up a contract with them. We do the buccal test in the pharmacy and send it off, so we do it for the patient, and then I schedule an hour consult with them to go over all of their results. And you're right, the report gives a lot of information that they don't necessarily need to know. So I'm very transparent with this. This report can change and will change. So it's a point in time, and also it's a piece to the puzzle, not the whole puzzle. I have a whole presentation I go with to kind of get them up to speed before I share their report. But I am really interested in if you have, and maybe you can't say this because it's CE, like recommendations with labs, or even just what questions we should be asking on the community side since we don't have access to hospital labs in this case.
Yeah, I think so. So we're a major health system, but actually the majority of our pharmacogenetic testing goes to commercial labs. So we actually don't have the in-house component. So we've had to ask a lot of these questions. There's a reference on my slide about selecting a testing laboratory. It's Vo et al. That paper is a little outdated, but really good. And then I can put the link in the chat. There's another paper that's a little bit more recent that kind of goes through the steps or questions that I think are relevant to anyone assessing labs. Um, I think it really is an institution specific decision in terms of some of the financial questions. So I don't want to advocate, but I know there are also like new emerging pharmacogenetic laboratories that are constantly coming out. One of the questions I didn't touch on, but I would comment on is doing a really thorough assessment of any genes they include that might also have disease risk, because I know at least in Michigan, there are differences in terms of the legal requirements for consent with that. And so that's one of the questions I don't think is always included on those results, but what are the potential disease implications and are you prepared to counsel on those? And if not, is there a way to exclude them? We I can't think of a lab we haven't worked with where we haven't asked for some sort of customization, and sometimes the answer is no, but I wouldn't be afraid to ask.
Perfect. That's great information. Also, you all mentioned it's great for pharmacists in the community to have this information because obviously when we're dispensing, the issue is there's very few programs that I'm aware of, and I would love to know as well, of integrating this data into dispensing systems for pharmacists. So I really tell the patient that at this point in time, they have to be an advocate for themselves when they take this report to other providers because we don't have access, obviously, to EHRs and things like that. So I think that gives providers, sometimes we require a provider order to do the test. And so I think that sometimes that's why they don't want to do it, because they don't know what to do with the information once they have it. They don't have a way to easily put it in the EHR.
Yeah, we have that concern as well. I would say our strategies are allergies, which are not ideal. There's problemless codes for like testing or even just one of the other neat features that I've seen, they did it in Europe initially, but I think there's a couple centers in the US that are doing it where they're creating patient education cards that have a QR code, and it will essentially link to the patient's specific genetic findings. Any provider can scan that QR code and it takes them to a resource like ClinPGX, where it'll essentially say, here's the current evidence for all of these medications with the patient's result. So I'm looking for it. I think there's a couple centers in the US that are going to do that, but that's one of the tools that I've seen that I think might be really helpful in the community space.
And also, if you want to send me those links to my email or whatever, I can put that in the thank you email to everyone so they have those resources.
Yeah, I'll include those citations.
Perfect. Are there any other questions? Well, thank you both so much for joining us. Like I said, I'll be sharing all the slides and those resources with you all later this week, as well as post this recording on our YouTube channel. So feel free to share or reference as a resource. Yeah, thank you both so much for joining us.
Thank you.
Thank you.
Thank you. This was incredibly helpful, I think, for everybody. So thanks for your time. Thanks for joining us. And thanks for the actionable presentation that you delivered. I hope you have a wonderful rest of your week. Bye.